Thank you. We have to talk about NAVA and ECMO, which are two hot topics in critical care today. First thing I want to tell you is that we really don't know how to ventilate patients on ECMO. There are no randomized control trials. There are a lot of reviews and meta-analysis, but actually no one really knows what to do. And also physiological data and studies are lacking. So usually we're all guided by our common practice and experience. I'm not going into ECMO details, just to tell you 2-3 basic concepts. The first one is that we're talking about VV ECMO. I mean a veno-venous bypass for respiratory support. And you have to remember that ECMO is quite efficient in supporting oxygenation. But if you want to oxygenate the patient, you need a very high blood flow. Because what determines oxygenation during ECMO is the ratio between the extracorporeal blood flow and the cardiac output of the patient. Because the way ECMO improves oxygenation is actually increasing the oxygen saturation of the mixed venous blood. So if you have a severely hypoxemic patient, you put him on ECMO, you want to oxygenate him, you need high blood flow, which means big cannulas and a lot of technical problems. While VV ECMO is much more efficient for CO2 removal. This is due to the different ways of transport of oxygen and CO2 in the blood, because you know that in one liter of arterial blood, there is almost twice of the entire metabolic production of CO2. So technically, you could remove all the CO2 produced by the body only with less than 1 liter per minute of extracorporeal blood flow. And this is the basis for the low-flow CO2 removal devices that Christian will talk about later. But despite all this, in the very first phases of ARDS, when the patient is really, really sick, what we do is control mechanical ventilation. Because even in these phases, even if you have a very efficient ECMO system, even if you remove all the CO2, these patients have such a high drive which we are not really able to control. So in the first phases, we usually go with fully controlled mechanical ventilation. But then hopefully, when the patient improves, what we want to do is to switch them as soon as possible to an assisted mode of ventilation. And the reason why we want to do that has been explained by Leo before, so I'm not going through those. But we want to go to an assisted mode of ventilation, and we don't really know which one is the best. Some people do pressure support, others do even CPAP. Some people tend to extubate the patient and do what they call awake ECMO. We think that there may be a role for NAVA in this phase. This slide is just to let you know that during this phase, there is a very complex interplay between the respiratory drive of the patient, the sedation we apply, and the ventilation of the membrane lung, which determines how much CO2 we remove. And sometimes it's very difficult to find the balance between these factors. So why do we think that NAVA can be useful? It can be used in these patients? Well, most of the advantages of NAVA had been presented before, but it's a potentially protective mode. And it has a potential for tidal volume and minute ventilation autoregulation, as we will see, improved synchrony, and preservation of diaphragmatic function. The first point is this, and this has been shown by this study in rabbits in a model of acute lung injury by Lucas Brander and Christer Sinderby. And they compared NAVA to injurious and protective volume control ventilation. And what they saw was that there was a decrease in all the inflammatory markers. So they showed that NAVA was at least as protective as 6 ml per kilo tidal volume control ventilation in the ventilation. And what they saw was that during NAVA, the animals were able to spontaneously choose a very low tidal volume, really actually below 6 ml per kilo. So they concluded that NAVA is a spontaneous assisted mode of ventilation that can in some way even prevent ventilator-induced lung injury. Okay, these are animal data. And we have seen in many studies comparing NAVA and pressure support that during NAVA, the patients tend to select a low tidal volume. And even if you increase the NAVA gain or NAVA level, you don't really see a sharp increase in tidal volume. And this is very different from what we see with pressure support. And this is a study we did in our ICU. And what's also good with NAVA, or at least we think it's good, is that there is a preserved variability of the breathing pattern, which is very different from pressure support, because as you know, with pressure support, you have a sort of monotonous ventilation. With NAVA, you have continuously changing tidal volume. And then this paper came out, and this is actually the first paper on the combination of NAVA and ECMO in 6 patients, so it's a very small patient series, in 6 patients recovery from ARDS, and the intervention was the authors wanted to change the ventilation of the membran lung, so to change the gas flow, and they wanted to see which were the ventilatory response of patients during NAVA. And these are the results. These are the tracings from one patient. So this is the FiO2 of the gas flowing through the membran lung, and this is the gas flow. You see that the support was quite low, only 2 liters per minute of gas flow. So what they did was to reduce and then stop the gas flow, which is equivalent to stop the ECMO machine. And okay, they didn't see a main effect on oxygenation, a little bit of decrease in PaO2, which was rapidly compensated by an increase in FiO2. But what they really showed was that, of course, you reduce the membran lung ventilation, you turn off the ECMO machine, and the patients immediately increase their ventilation. So EDI increases, and tidal volume increases. This is the only patient among 6 who went slightly above 6 ml per kilo. All the other patients kept their tidal volume within 3 to 6 ml per kilo. And they all were able to compensate the pH change by increasing minute ventilation, more increasing respiratory rate than tidal volume. And so these authors concluded that NAVA during ECMO is a sort of closed loop automated ventilation. You have seen this slide at least 3 times during the meeting, so I'm not going through it. Just to remember you that synchrony between the patient and the ventilator is very important and has a relevance also for the outcome of the patients. And you know that NAVA is important for the inspiratory synchrony, inspiratory trigger synchrony, but I want to discuss a little bit with you the issue of expiratory triggering. This was a patient that we ventilated with NAVA during ECMO. It was a patient with severe ARDS and very, very stiff lung. You see, this was the respiratory system compliance. It was only 7 ml per centimeter of water. What we did was we tried to ventilate him with pressure support with the usual trigger of 30% of peak flow, and it was impossible because we had a lot of double triggering. So we thought, okay, we can reduce the trigger off to the minimum allowed by the ventilator in order to increase as much as possible the inspiratory time. But even putting the trigger level from 30 to 1%, we weren't able to solve the problem. And the problem was solved with NAVA, because we have seen that with NAVA, the expiration is controlled by the brain. And so we did a study in 10 patients, in 10 ARDS patients with a very low respiratory system compliance. You see, compliance was on average 18 ml per centimeter of water. They were on full support, let's say more than 3 liters per minute of ECMO, and they were ventilated for 23 days, and they had been on ECMO for 19 days. So I would say reasonably severe patients. And we did 3 steps of 30 minutes each in random order. The first one was pressure support with the common expiratory trigger. The second one was pressure support with the 1% expiratory trigger, and the third one was NAVA. In the 3 steps, we kept the same PEEP, FiO2, and ECMO settings. and we assessed the asynchrony index. And the results were that, you see, we saw a significant difference of respiratory rate with NAVA, and this is probably because this was due to double triggering, so the ventilator was counting 2 breaths instead of 1. A significant increase in the inspiratory time, and a significant decrease in the asynchrony index with NAVA. And this is the plot representing the decrease in the asynchrony index. So we have shown that NAVA during ECMO is feasible, at least when the patients are recovering from ARDS, and that the patients are able to auto-regulate the tidal volume and minute ventilation, and this can be modulated also by decreasing or increasing a little bit the gas flow in order to find the appropriate setting for the patient in that moment. And then I'm almost done. This is a very interesting case which was published by Adrien Rosé, because this is a situation which is very common in the clinical practice, and sometimes patients are put on ECMO because they have signs of barotrauma, because they have air leaks, pneumothorax or bronchopleural fistula, and these patients are really, really difficult to ventilate. And for example, this is a very interesting case. This patient had a large bronchopleural fistula, and they weren't able to ventilate him with pressure support because due to the leak, the ventilator was kept auto-triggering. Then, to manage the fistula, they increased the aspiration of the chest drain to -15. So they said, maybe we can ventilate the patient by decreasing the sensitivity of the trigger, of the pneumatic trigger of the ventilator to -15. But if you put a trigger to -15, it is something you don't want to do, because the patient is not able to trigger the ventilator unless he does a huge inspiratory effort, which is something we don't want in these patients. And so, and even with NAVA, if the pressure trigger was to -1, there still was the problem of auto-triggering or not very good patient ventilator synchrony, but they solved the problem by putting the pneumatic trigger with NAVA to -15, and so every breath was triggered neurally, and they were able to ventilate the patient. So my conclusions are that NAVA is a potentially protective mode of ventilation, that NAVA may unload the muscles without reaching unsafe tidal volumes. It improves synchrony, this we know for sure. It's particularly promising in patients with extremely low compliance and with air leaks, which are very common situation in ECMO patients. And of course, more studies and patients are needed. So let me thank the organizer for inviting me, Krista and Jennifer, for all what they have done for me, and you for your attention. Thanks.